I talked yesterday a little bit about the importance of focal infection in chronic degenerative disease, and I'm going to give you a little bit more of the hardcore evidence for that today. But I'll start out again one more time by saying that well over 80% and probably 90% of all chronic degenerative diseases, basically all disease, is initiated and fed, propagated, and worsened by the oxidative stress from the toxins that are released by chronic focal infections, and that these infections, greater than 90% of the time, are in the oral cavity, in the form of chronically infected tonsils, chronically infected lymphatic tissue, occult abscesses, infected teeth in the form of root canals. And what I've now found going through the literature, and I was quite stunned to see this, the incredible number of adults throughout the world, and it varies depending on the country, has to do, I suppose, to dietary habits, etc., but an enormous incidence of chronically infected teeth that have never been instrumented. Okay, they don't have a root canal, they don't have a filling. Some of them might have a filling, but many, many teeth just at a certain point in time, because of your poor dietary habits, because of aging, because of trauma to the teeth, because of poor thyroid status, allowing infections to take hold, because of poor estrogen or testosterone status, same thing. All of a sudden, or relatively all of a sudden, these teeth start abscessing. They start developing pockets of pus that can sometimes present as acutely painful infected teeth, but the vast majority of the time, they're just sitting in your mouth like little time bombs. They feel perfectly fine, and they're absolutely the primary reason why you have your cancer, your heart disease, your arthritis, your high blood pressure, your whatever your chronic degenerative disease is. I'm going to do a quick recap of these oxidative stress concepts we've been talking about the whole conference, and that all chronic degenerative diseases share the one common denominator of increased oxidative stress. And the things that most commonly are involved in chronic disease are infection-related toxins, toxins that are unrelated to infections, inadequate or suboptimal supplementation or ingestion and processing of quality nutrients, increased oxidative stress from compromised metabolic pathways secondary to genetic deficiencies, and the big one we've been talking about for a couple days now, the hormonal imbalances and the subclinical hypothyroidism and the subclinical hypoestrogen and hypotestosteronism. Now, when we use the term increased oxidative stress, what do we really mean? We're basically saying that that's a point in time where the production of free radicals, aka toxins, are chronically exceeding the body's antioxidant capacity to neutralize them. And the state of increased oxidative stress at a physical level is represented by excess levels of biomolecules that have already been oxidized. And these include RNA, DNA, enzymes, structural proteins, and lipids, and sugars. What do all toxins infections have in common? All of them, infections and toxins, cause cell and tissue damage by increasing oxidative stress, period. Now, how can one thing like increased oxidative stress have such a wide variety of clinical appearances and clinical expressions? It has to do with a combination of these 5 factors. Which specific intracellular organelles, mitochondria, etc., cells, tissues, and extracellular areas of the body have the increased oxidative stress? So where is the oxidative stress precisely located? Number 2, what are the biochemical qualities of the pro-oxidant toxin that is accumulating and causing this damage? I talked yesterday about the difference between cyanide and mercury, for example. So the biochemical nature of the toxin strongly affects how profoundly and specifically it's going to oxidize and neutralize and impair the function of a biomolecule. What are the genetic predispositions present, which basically translates to enzyme or biomolecule deficiencies that further facilitate and allow a force to cause oxidative stress to develop in an area. And then, of course, number 4, how long has the oxidative stress been going on, also representing a further accumulation of oxidized biomolecules. And number 5, how severe is the oxidative stress? Is it just a little bit, more than a little bit, a lot, or an overwhelming amount? And those factors all together determine how this one thing called oxidative stress might be causing lupus in one person, hypertension in another, Alzheimer's in another, Parkinson's in another, chronic coronary artery disease in another. Now, redox physiology and the nutrient-toxin relationship. Okay, the defining property of a nutrient is its ability to metabolize down into one or more substances that has the ability to donate electrons or reduce. So, as a simplification, but not an oversimplification, antioxidant equals nutrient, and nutrient equals antioxidant. Then, the flip side of the coin, the toxin, is defined by its ability to directly take away electrons or cause a messenger to directly take away electrons. But bottom line is oxidation takes place, and that's how a toxin is toxic. Pro-oxidant equal toxin, toxin equal pro-oxidant. Now, and just to hammer the point one more time from a different direction, if something that you think is toxic is incapable of taking molecules from another, electrons from another molecule, it's not in fact toxic, okay? So even though the clinical manifestation of a toxin varies widely, the damage it's doing to individual biomolecules is the same. All right, now, I mentioned the different characteristics of oxidative stress, how they affect the manifestation of a clinical syndrome. Well, I'm going to outline some factors now that show you how a given toxin, even though its final common effect is oxidation of a biomolecule, how you could have so many different manifestations clinically of this final common denominator of oxidative stress. And it has to do with number 1. What is the solubility characteristic of the toxin? Water soluble, fat soluble, water and fat soluble. Number 2, molecular size, okay? Vitamin C is a small molecule. It gets everywhere. You have huge molecules that are toxic, and they're going to have the ability to only access certain areas of the body, and they're not going to accumulate or present anywhere else. Number 3, is there an ionic charge on the toxin? Something that's neutral can pass through pores and cell walls much more effectively than something that's highly charged and ionic, and this determines how much a toxin gets into a certain area. Number 4, physical mass of accumulation. Think about this. You could have a toxin that might not have a huge impact in a certain area of the cell, but after you've been accumulating this toxin for 20 years, you actually have a physical mass of toxins in there, such to the point that it's crowding out biomolecules and keeping critical biomolecules from physically accessing each other and interacting. Number 4, how do the toxins, do they specifically affect an important intrinsic chelator in the body? Glutathione synthetase, for example. Some toxins initiate oxidative chain reactions. That affects it. Now, this is, okay. At some point in time, when you start banging this around in your head a long enough period of time, you might ask the question, when vitamin C is oxidized or any other antioxidant is oxidized, it's toxic because now it needs to take up electrons. So this begs the question, what's the difference between an oxidized antioxidant such as oxidized vitamin C, dehydroascorbic acid, and a toxin? They're both looking to pick up electrons. And I just said picking up those electrons is the sole reason why a toxin is toxic. Well, number 1, in advanced disease states, you start to have a lot more of the oxidized forms of an antioxidant than the reduced, and that does exert a toxicity. But the main and complete important difference between these two species of molecules is that the chemical stability of an antioxidant is very similar, whether it's in its reduced or its oxidized state. The chemical stability of a toxin is vastly different, such that once a toxin takes electrons and oxidizes a biomolecule, it's so chemically stable it's not going to give up those electrons again. So it doesn't become a nutrient that can donate the electrons somewhere else. So what a toxin does is it takes and keeps electrons, whereas good antioxidants will donate electrons and then take electrons from other antioxidants, donate them, and contribute to electron flow. So a toxin takes and keeps and stops or impairs electron flow inside the cell. Another reason why you have a significant degree of toxicity. So, okay. Now, remember that all biomolecules in the body can exist in a reduced or oxidized form. A very rare species of molecule is chemically inert. So basically, all of these biomolecules are either oxidized or reduced, and all molecules in general are going to be either prone to give up an electron or take an electron. Now, when biomolecules are reduced, they have their optimal state of bioactivity, okay, like a newborn baby. But as you get older, your lack of physiological function is not because the biomolecule is wearing out. It's because a greater percentage of those biomolecules are oxidized now rather than reduced. And that's the cellular hallmark of aging. The cellular hallmark of aging is are your biomolecules reduced or oxidized? And if a lot of them are oxidized, remember the redox equation, you have reduction oxidation. So newborn baby, reduction, oxidation. You get older, you get older, you get older, then you finally start getting chronic degenerative diseases, and you start having as many or more oxidized biomolecules as reduced. The molecule itself, age is irrelevant. All right, there is absolutely no difference between a non-oxidized piece of DNA and that same non-oxidized piece of DNA 200 years later. The only differences are when it gets oxidized and when the actual percentage ratio starts to change. And as Dr. Ron mentioned in the presentation, how advanced this perturbation of redox balance gets directly dictates how vital the microcurrents are and the electricity in your body. Okay, you have definite microcurrents and you have optimal microcurrents, and these are only optimal when the balance of reduced and oxidized biomolecules in the body is strongly in favor of reduced. Okay. All right. Now, having reiterated those principles of chronic disease and what causes all disease, now let's go into, I mentioned this yesterday, but I want to re-highlight it, what I consider to be the treatment principles, the treatment basics that you have to always address to give a complete and thorough treatment or therapy to your patient and give them their optimal chance of improving, getting better, and in rare circumstances, even completely resolving a chronic disease. Number one, prevent or minimize new daily toxin exposure. Environmental, dietary, digestive, dental. Number two, you want to be able to neutralize, which is to reduce, donate electrons to the existing toxins that are present in the body, so they're no longer able to take electrons away from the biomolecules you want to protect. Number three, for the toxins that are already present in your body, you want to be able to remove them in as effective and non-toxic a way as possible. Remember, detoxification is also retoxification. When you take toxins out of the body, generally they've accumulated in a certain area and they're relatively non-toxic because they've taken their electrons from biomolecules and they're not doing anything else. Once you start pulling those toxins out of the cells, not 100% of the toxins that you pull out are going to be excreted. And some are going to circulate and be redeposited in new, previously unpoisoned tissues. Number four, you want to resolve infections. And you want to use protocols, and I would submit to you to think again about the ascorbazone protocol, because you're not always, and maybe quite frequently, you're going to be unable to identify clearly and diagnostically where the focal infections are in your body. But you're going to know they're there, and you need protocols that will, as non-specifically and efficiently, knock out infections as best as possible. Something I don't have in this presentation that'll probably be the basis of approaching these things clinically is, and it's very important, but I'm just going to mention it briefly because I have so much other material, the overwhelming importance of following lab data that indicate increased inflammation and oxidative stress in your body. AKA, the most important one is the high-resolution C-reactive protein test, okay? Just like iron, where the entire normal range is out of normal, it's pretty much the same thing with CRP. Just about everybody has chronic infection. They have a derangement of their body-wide oxidative stress, and this is reflected in an elevated CRP. The LabCorp calls the normal range of CRP 0 to 3. Well, anything over 1 is undesirable. Above 3 is highly undesirable. But just remember, because I'm going to show you where a majority of the world's population has chronic infections in their mouth, that also goes on to mean that that group of people is affecting their CRP, and they were the population that generated this, quote, normal range of CRP. So, all the mechanisms that you use to actually treat patients like this, you're very limited in what you can use to see that you're having the effect that you want. And I will submit to you that in addition to the things we're going to talk about in death by calcium later today or tomorrow, later today, you need to have tests that show you you're doing the right thing, okay? When you're depositing calcium in your body, you're not doing the right thing. So your coronary calcium score is important. Uh-oh. I'm not touching anything. Yeah. And with the CRP, this is very important. If you're doing the right thing, the CRP is going to come down. And you're not really looking at a totally normal situation until that CRP is below 0.5. Okay? And don't get me wrong, a lot of people can live a long time within the quote-unquote normal range of 0 to 3, so a 1.5, a 2, a 2.5, and they're taking a lot of quality supplementation. That's not a death sentence, but I tell you what is a death sentence. When CRPs are chronically above 3, you have a not too distant date with the Grim Reaper if you can't bring that down. Number 4, supplement or eat optimally. Number 5, address hormone imbalance. All right. Now we're going to sort of focus and hone in on the truly most critical factors that cause morbidity and mortality on the planet today, that make people sick, chronically ill, and ultimately kill them. Number 1, root canal treated teeth. However, I want to say quickly, and I'll talk about this a little bit more later, even though Dr. Kulatz and I wrote a book called The Toxic Tooth that pretty much makes root canals a bad guy all the time, I'm going to tell you that while there is never a circumstance that I would recommend to a patient that their best alternative is a root canal, when the patient refuses certain other interventions and doesn't want to consider having a tooth extraction, a properly done, this is the biggie, a properly done root canal can render a severely infected tooth much less toxic, not non-toxic, but less toxic. Anyway, in general, root canal treated teeth are to be avoided, but I'll talk about the exceptions later on. Other chronically infected teeth, this is the biggie. I had a close friend who was getting some root canals extracted, and in the course of the routine dental x-ray, this is about 6 months ago, there was a huge infection on a non-root canal treated teeth right next to the other tree. And I said, wow. I said, does that hurt? She said, no, feels fine. It was also affecting the sinuses and causing a chronic sinus infection. And I said, well, you know, that tooth has to come out too. I said, and she reluctantly agreed, and she got a whole lot better. The point I want to make is, if she hadn't been getting her root canals extracted and she hadn't gotten that x-ray on her mouth, she would have had one of the most toxic things you could possibly have, severely impacting your health, and you wouldn't know anything about it. Okay? That's why this is called asymptomatic, painless teeth, okay? Not a minority of the time, but most of the time, a severely infected tooth feels fine. Unless you make a point of looking for these infected teeth, you're not going to find them, even though they're going to give you a heart attack, cancer, or kill you just as quickly as a root canal. So, there's a typical x-ray picture. We'll go into that. Another source of oral infection and toxicity that obviously should be obvious to most people, that profoundly impact your health and can kill you in a few days to a few weeks, is an acutely symptomatically infected tooth. So when you have a big old tooth pussed out, you need to get that out right away. Chronic periodontal or gum disease, very, very well-established factor that increases your chance not only of heart disease, but all other chronic diseases. Cavitational gangrene, the routine way in which teeth are extracted routinely leaves an infected hole in the jawbone with the pathophysiology and toxicity identical to wet gangrene. And I mean, what do you do when you have a gangrenous limb? Pretty much, unless after the antibiotics and ozone fails, you got to get it cut off. But you don't leave wet gangrene inside your body and expect your body to react well. Chronically infected tonsils, we touched upon this the other day, and not a minority of the time, but the vast majority of the time, chronically infected tonsils, usually that have become chronically infected due to the fact that you have a history of advanced gum disease feeding the tonsil, or a previous root canal draining the tonsil. The vast majority of the time, these tonsils look perfectly fine, and there's no clinical episodes of tonsillitis or anything like that. The tonsil is a weak protector. By that I mean, you know, if you have a small self-limited oral cavity infection, the tonsil can drain it and deal with it and process it, and everything's fine. But when you have a root canal or a other chronically infected tooth just continuing to drain into that tonsil, the tonsil not only becomes worthless in defending you against that infection, it becomes a focal infection itself. As I say, the protector becomes the infector. Then there's infected dental implants, and there's toxic metals. So, a little bit has changed since I did this slide, and I'm going to swap places, believe it or not, of number 1 and 2. And I'm going to tell you in terms of overall public health, the primary reasons for most, and when I say most, I mean a good 90%, of chronic degenerative diseases developing and being sustained are asymptomatic or painless infected teeth, root canal treated teeth, infected teeth that are symptomatic, chronic gum disease, and bear in mind, chronic gum disease is what frequently leads to 1, 2, and 3, and chronically infected tonsils, which is usually secondary to 1, 2, 3, and 4. Now, just a little background data, and this is published in the Toxic Tooth as well as some other places. Back in the day when Dr. Huggins was first starting out on this, how long to when? 9 what? 9:25. Wait, no, I had 9:45 before. What you doing to me? What did I say here? 9:45. 9:45. Okay, gotcha. Okay.
No, 9:45. It's 9:15, but we're going to add 10 minutes.
Oh, God, all right. All right, turn your what are your hearing aids on a little higher. All right. Oh, flustered. Okay, 5,000 consecutive root canal treated teeth were extracted and analyzed by Dr. Boyd Haley at the University of Kentucky. 100% of them had highly potent toxins in them. And it wasn't due to the extraction because they looked at teeth that were extracted for orthodontic reasons and they were perfectly normal, no toxins. So remember, all root canal treated teeth, all asymptomatic painless teeth, all chronically infected gums continually produce endogenous toxins as the pathogens proliferate. And the variety of toxins is staggering. Ron showed you the number of toxins on his tooth the other day, and you also have fungi, you have viruses, you have protozoa. And this is one reason why so many people's infections are different, and their immune systems are different, and how it impacts them is different. That's why this isn't just a rubber stamp thing, and everybody's going to react a little differently. Okay. Corroborating this, when they looked at root canal treated teeth in 3 separate studies, they basically showed that 100%, 30 of 30, 21 of 21, 34 of 34, had these associated pathogens. So once the process has been done, the pathogens are there. And the only thing left to do is to either extract the tooth or have the root canal done in such a quality fashion that you're pretty sure there's no leakage taking place from the infected upper part of the tooth into the lower part of the tooth. So it's a fatally flawed procedure. The immune system no longer has access to the tooth. You have a natural fluid flow in the mouth that goes from the inside out, that once you have the root canal done, it goes from the outside in, so it continually brings in new pathogens. And the success of it is generally just based on whether it's pain-free or not. And since most of the time you cut all the nerves involved, you relieve the pain, even though you did nothing for the infection. So for the molars and the larger teeth, this represents not only the root canal, but the other chronically infected tooth, a perfect endogenous delivery system for toxins and pathogens. Some of the highest pressures that can be generated anywhere in the body are between 2 opposing molars. So you chew and you squeeze these toxins and pathogens out even more effectively than if you whipped them up and put them in a syringe and gave them IV, because they're also going into the lymphatics, and where, for example, they exchange very freely with the lymphatics of the breast. I'm going to tell you, infected teeth are behind at least 70% of all breast cancer. Anyone who has breast cancer that doesn't have a thorough dental examination is missing the single most important thing they can do to not only arrest their disease, but have a good shot at curing it. So, root canal treated teeth and the other infected teeth have a unique pathogen flora, and this is why we have a variability in the presentation. The tooth involved, if it's a small incisor, you don't chew on an incisor, so you don't squeeze the toxins out like you would be between molars. You have your genetic predisposition, how long the root canal's been there, how good your supplementation, the status of your hormones, and the age and general health of the patient, okay? I mean, it's kind of like sometimes we just expect an 80-year-old that's had an extraction to heal bone in and take an implant just as well as a 30-year-old. Well, I mean, look at their x-ray. They have osteoporosis everywhere else in your body. How well do you expect given interventions to heal in the mouth of an 80-year-old versus the mouth of a 40-year-old? All right. Now, the crux of this presentation is the chronic apical periodontitis tooth. Periodontitis means where the gum comes in, goes down the side of the tooth. Okay, that's the periodontal area. And when you get down to the apex of the tooth, this is where you see the x-ray evidence of infection. So I'll read this quickly. Apical periodontitis is a group of inflammatory diseases caused by pathogens infecting the necrotic root canal system. So when you see this area on x-ray that shows a big accumulation of pus or inflammation, by definition, the pulp of the tooth is already dead. It's necrotic, it's dead. You will not see this if you have a vital tooth. So it's an x-ray evidence of a dead tooth with the toxicity approximating gangrene accumulating at the tip. It often appears after a poorly done root canal. By that I mean it doesn't get sealed well, and so the infection of the root canal starts to drain, and you form this. It often disappears after an expertly done root canal. That's why I say there's a variability on how root canals can impact your health. As I said, this radiolucency always means there's chronic infection in a dead tooth pulp, and it always means pathogens are present, okay? There's not really any other reason to have this x-ray picture. As a matter of fact, they have an interesting story where they looked at rats that they raise in a germ-free environment, okay? And when they exposed the pulps of these germ-free rats, so there's no germs in the mouth either, no apical periodontitis developed. So you always have to have pathogens to have this entity present. So it's very reliable. The point being, it's very reliable when you see this x-ray change that you have this pathology present and you have the patient wide open for any severe chronic degenerative disease there is. And then, to me, one of the most amazing things, but it's a fact, as ugly a process as this is, looking at a tooth get chronically infected and developing pus, and is the vast majority of the time it's asymptomatic. So unless you have a reason or a suspicion, or what I'm going to tell you should be routine, and you don't look for this, you're not going to find it, and you're never going to have an opportunity to do the single most significant thing in restoring your patient's health. Now, regular x-ray, just panoramic, regular x-ray, nothing special about it, will, on root canal treated teeth, will show evidence of this, I'm going to call it CAP, okay, cap. Shows evidence of this infection, this cap, 40 to 70% of the time. So that's one reason why so many root canals are so toxic, is because you never really get rid of the bulk of infection at the tip of the tooth, but they try to. And then when you do this new technology called 3D digital x-ray examination, you can find some degree of this cap present as often as 90% of the time with root canal treated teeth. Okay. Now, this also means that 10% of the root canal treated teeth don't show the cap, and I will tell you that those 10%, the root canal might be a good non-toxic procedure for that 10%. It's just very difficult to know ahead of time who's going to fall in what category, which is why this is going to be less than a enthusiastic support for root canals under any circumstances. So when they looked in a controlled study at the same 46 root canal treated teeth, they found 70% of the time on regular x-ray the evidence of infection, and 91% of the time they found the infection with 3D exam. Point being, there's more and more of these devices out there in dental offices right now, but still most of the time when you get a dental x-ray, it's a Panorex, it's a regular x-ray. And while if it's a very well done regular x-ray, you have a moderate reassurance that that tooth is in good shape, you obviously have a huge percentage that's being missed, okay? Just like I think ferritin, for the reasons about iron, should become a routine blood test in the management of your patients. I think getting to know an endodontist or an implantologist or a very high volume dentist who has this type of equipment, you need to have your patients start getting baseline 3D examinations of their teeth and repeating these tests periodically every couple years, okay? If you don't look for it, you won't find it. I like to say, and if it seems like it's too much of a trouble to look for something, well, you know, you do a blood test, you do a biochem panel, and you get a glucose level. Oh, there's a glucose of 350. She's diabetic. He's diabetic. Would you have any idea that that blood sugar was 350 without measuring the blood test? No. Would you have any idea there's a huge asymptomatic abscess tooth on x-ray if you don't x-ray it? No. So be aware of this pathology, look for it, and address it, and your patients will do phenomenally better. And you'll actually start to see occasionally resolution of what are considered currently still to be incurable diseases. There's the periapical infection. You see that area at the tip of the root? This is in a root canal treated tooth, okay? That's a fairly large space. You'll see lesser spaces. They all represent infection, but the bigger the space, the more clinically impactful it is. I mean, basically, the more necrotic material you have, the easier it is to push it into the lymphatics of the blood supply. Now, here's a tooth. In this particular case, there's an enormous amount of decay, which doesn't necessarily have to be in place, but no root canal, and yet there's still a large area of infection on the one side and a lesser area of infection on the other. Now, this is a tooth that must be extracted and cleaned out correctly. Now, if the patient says, I can't afford an implant, I can't afford anything else, I don't want an extraction, do anything you want, doctor, but don't do an extraction, I'm not permitting you to do an extraction, then a root canal is an alternative. Because an expertly done root canal that evacuates all that pus and seals the apex well enough so that no new x-ray findings develop over the next 6 months, that patient will be much better served by that root canal than leaving that tooth unaddressed. That's the circumstance under which I recommend a root canal, when the patient is not permitting the dentist to do the game plan that he or she wants to do. So, people with this CAP finding have almost 3 times a higher risk of coronary artery disease, independently associated. Cardiologists now consider inflammation to be the primary cause for atherosclerosis. And old Dr. Huggins, as I said before the other day, you can't dry off while you're still in the shower. So it means you're not doing a whole lot of good for your patient, giving them a ton of antibiotics, refining their diet, doing everything you know that's correct, and leaving an infected entity like this, number one, undiagnosed, and then number 2, unaddressed after you've diagnosed it. Pathogens cause the chronic inflammation. These, the DNA of oral pathogens, typical for root canal and gum infection, has been consistently found in the coronary atherosclerotic plaque. Period. That's pretty compelling. And as you saw with Dr. Ron's slide, the diversity of pathogens is huge, where they core out these plaques and then examine them, like roto-rooter the plaque out. You see greater than 50 or more different species almost all of the time. Here's what I talked about in that vitamin movie yesterday, and this was put the final nail. I get so irritated now when I hear, oh, well, there's an association, there's a link, this, that, or the other. We now have the smoking gun study. The smoking gun study was Dr. Pesci in Finland, and guess what? This was published in the Journal of Cardiology, and I don't know any cardiologists that still care that this article was published in their journal. 78% of the patients with root canals and 35% with chronic gum disease, they sucked out the blood clots that caused the acute heart attack and then did PCR testing. And they found 16-fold, 1,600% higher concentration of root canal and gum-related pathogens inside those plaques, inside those blood clots that are in the surrounding blood. That's cause and effect. You didn't suddenly develop a blood clot, and then for some reason pathogens started concentrating in it. That's asinine. So this clearly shows no link, no correlation, no risk factor. This shows cause and effect. The root canal treated tooth or the chronicle apical periodontitis tooth that has the same pathogens in it and the chronically infected gums directly cause, listen to this, are the direct cause greater than 90% of the time of all heart attacks. Okay? The 55-year-old that gets a heart attack, yeah, he's unlucky, but that's not why he got the heart attack. He had the wrong dentist, or he had a physician who didn't properly diagnose his dental condition, which is what I'm trying to impact here. So, and this is the study that shows that if the dentist is forced to leave the CAP tooth in and does not have the option of pulling it out, that a properly done root canal is better. And that is, they had a test where they looked at atherosclerotic burden in the aorta, basically what's your proneness to develop atherosclerotic plaque. And they showed that people that had CAP teeth left untreated developed a lot of plaque in the aorta, but when they did a root canal and post-root canal eliminated that CAP space, there wasn't any evolution of the atherosclerosis. So the other point here is if a root canal needs to be done, a regular dentist should not do it. The highest volume endodontist should do it in giving the patient their best chance of a successfully sealed off procedure. And the patient should just be hit with a battering ram if the root canal doesn't work and the CAP continues to accumulate. They need to be told in the strongest terms, you're threatening your life by not getting this tooth extracted. Don't keep on getting root canals redone when it shows that your anatomy just doesn't allow it to be well sealed off. So, we have a ton of studies that show regular periodontitis, not advanced periodontitis, not periodontitis at the tip of the tooth, is associated with every chronic degenerative disease there is. It's amazing. It's just sitting there in plain sight or sitting there hidden in plain sight. So, if regular, simple gum disease is associated with pancreatitis, hypertension, lupus, you just go on the list because believe me, they're all in there. They're all in the literature. If simple gum disease is related to this, how strongly related do you think is a huge accumulation of infection in that tooth? Huge. Now, Yes.
I just want to mention properly treating a root canal, as you mentioned, treating it with ozone to kill the infection.
Ozone helps stabilize a lot of these teeth, but you have to document on x-ray that you're not reaccumulating the CAP. Yes. Then I stumbled in the literature, and guess what? This CAP, asymptomatic, is very, very common. But you don't find it if you don't look for it. Using the calculations of these studies that I looked at basically all the different countries of the world, they all have their own studies of prevalence and incidence of this entity. And you consider the resolution improved of 3D X-ray over traditional X-ray, and the fact that most of these studies, because it's sophisticated equipment and expensive equipment, was done with regular X-ray and not 3D X-ray, I can tell you, I'm crunching the numbers for you. I'm not going to bore you with every single statistic, but I'm going to tell you that in the adult population worldwide, and including the United States, the CAP can be present in roughly 10% of all teeth. I hope that shocks you, because this is the cause of chronic degenerative diseases, and this is the one single thing that you can most do to reverse or cure your patient's cancer, keep them from getting their breasts taken off, take their anti-nuclear antibody titer from enormous down to 0, cause arthritis to magically disappear, stop migraine headaches, have Alzheimer's patients' brains start lighting up and thinking again. The impact of this is overwhelming. Okay? Form alliances with your dentists. Work out a situation where basically a good 3D exam should cost about $300. You know, so maybe you can tell your dentist, I'll send you a lot, charge them $200, whatever. It should become a baseline part of the workup of every patient that you have that has any medical condition and is coming to you for something other than, well, actually, you should do it even if they're coming to you for a well-person evaluation. It should still be part of the baseline workup. Just remember, how would you treat diabetes if you couldn't measure the blood sugar? How would you know diabetes existed if you couldn't measure the blood sugar? Answer, you couldn't manage it, and you couldn't diagnose it without the fasting blood sugar. Same thing here. This is painless. People don't know they have it. All they do is continue to chew on infected teeth and get sicker and sicker and sicker. So you got to look for it, and then you have to know how to approach it and deal with it. In the process of writing my 11th book on precisely this issue, and to your point about ozone, it's going to have lots of suggestions in there as to how to use ozone. Ozone is magic gas, as I said before. It's incredible stuff. It's doing things to infections that we never thought could be done, certainly not that I never thought could be done. And when you use it judiciously, there are many times, even if you can't resolve something like this, like I said, if you can get a CAP on a root canal tooth to disappear, and combined with a CRP that drops down to 0.7, 0.6, 0.5, if you have no CAP and a normal C-reactive protein, you got a pretty good assurance that, number one, you're in good general health, and number two, that tooth is not negatively impacting your health. And one of the things that's going to bring that CRP into line is going to be normalizing the hormones. Remember what I said before about low thyroid function allowing focal infections to take hold. Okay? Even though the vast majority of patients with heart attacks have root canal treated teeth. Dr. Broda Barnes showed some 30 years ago that it didn't really matter what you had going on in your mouth, because if you kept your thyroid function perfectly well regulated and adjusted, there was virtually no incidence of heart attack in that population. So thyroid, estrogen, testosterone, it's one big ball. You got to take care of it all. All right, I'm going to fly through the rest of this. A lot of this is just other studies that I cited that showed how common this chronic apical periodontitis is. See, Belgium, Nigeria, and all of these things crunch down to the fact that under your most conservative estimates, at least 5 to 7% of all teeth in adults have this CAP. And now look, you know, how many people above 60 have no chronic degenerative disease at all, take 0 prescription medication? Not too many that I know of, okay? And that's because when you collectively look at all the teeth, the vast majority of them have at least one CAP tooth sitting in their mouth, undiagnosed, unextracted, or improperly root canaled. Now, just to make things a little dicier, when you have implants or permanent bridges in your mouth, for a permanent bridge, you have a space right here, and then you have 2 normal teeth. And sadly, but it's the way it's done, I have several, you have to shave down the normal teeth to put the bridge on. So these normal teeth that you shave down to hold the bridge in place are called abutment teeth. Well, when you consider the fact that you've shaved away a lot of the tooth, they're getting a lot of stress and strain, and all these, we already know how common CAP is. Well, as it turns out, nearly 50% of abutment teeth have CAP. Okay? And 25%, 50% that had root canals have CAP, and a full 25% of abutment teeth that did not have a root canal have CAP. So this is some place to particularly focus. Just don't look at all the other teeth. Look very carefully at the teeth that have been instrumented the most. The teeth that have been instrumented the most are going to have your highest incidence of this type of affliction. And here's what I'm saying. Here's the abutment tooth. See the bridge? And then you see, and it's not been root canaled, and there's your big old CAP there. I mean, it's, your patient's not going to want to lose their bridge or their tooth, but I guarantee you your patient wants to lose their life even less. So, all right. And this applies obviously to CAP teeth too, since they already have the infection that a root canal is treating, but it's been established for some time now that just having 1 or more root canal treated teeth in your mouth statistically means you're substantially more likely to have a heart attack, period. This should be part of the informed consent, but it's not. I mean, I still have no problem with anybody getting a root canal, but I have a great deal of problem with people not being informed as to the very readily available data that we have in the literature now on their chance of heart attack and severe disease with these deliberately induced infections in the mouth. So, okay. Okay, so I want to make the point one more time. They have a regular 2D X-ray called Panorex, and then they have the 3D X-ray. So here's the Panorex, and here's the 3D, and you can see the sinus, you can see the root canal treated tooth, and so you can see directly how this tooth is feeding infection directly into the sinus. Here's another one where there's no root canals, but obviously they have two crowns. Those have been instrumented tooth, and they too have spaces at the end, and they're actively invading the sinus and filling the sinus with pus and mucus. So, all right. So I'll wrap up, and I'll tell you, number one, the single most important cause of atherosclerotic and heart attack are chronically infected teeth. And I'll also tell you that the single most important cause of cancer of the head, neck, and chest or breasts is infected teeth. This is a laundry list of the diseases in the literature associated with periodontitis. A little more information on tonsils. You have this presentation in your sticks. There's the Broda-Barnes information, thyroid hormone. Also for thyroid function, very important, wrap it into this, is most of these people that have slight hypothyroidism have intracellular hypothyroidism and not glandular hypothyroidism, which means that their thyroid function tests come back normal. You need to do reverse T3. And Dr. Ron can tell you more about that, but it's only when you do the reverse T3 is when you see whether the cells in the body are converting enough thyroid hormone. Even though all the hormone T4 is produced in the thyroid, 80% of that T4 is converted to the active T3 inside the cells throughout the body. Got nothing to do with the thyroid gland. And that's the ratio that you look for. You look for a ratio of regular T3 to reverse T3 of 18 to 21 over 1. Okay. So I want to finish with this point. All patients with suspected or established coronary heart disease, and I say coronary heart disease because we have the proof on that, but you can substitute for coronary heart disease any chronic degenerative disease, must have a baseline 3D digital x-ray of all teeth and jawbone areas. If the test is negative and a clinical decline is noted after a period of stability, then you got to repeat the test because these infected teeth can just pop up for no reason at all, and the only thing you might notice has nothing to do with the mouth, but just a general decline in health or a worsening of arthritis or a worsening of autoimmune disease. So this test has to be done to optimize the benefit to your patients. Okie doke. Thank you.
Excellent job.